I would now like to introduce Associate Professor Stephen Adelstein, who is the Chair of the New South Wales Board of the Medical Board of Australia and a practitioner member of the National Medical Board of Australia. He has been involved in medical regulation since 2008, initially as a member of the former New South Wales Medical Board and a past member of the Medical Council of New South Wales. Associate Professor Edelstein is Head of the Department of Clinical Immunology and Allergy and Director of the Central Sydney Immunology Laboratory at Royal Prince Alfred Hospital. He is Clinical Associate Professor of Medicine at the University of Sydney, where he teaches medical and science students. In addition to his clinical and academic practice, he oversees undergraduate and postgraduate research and is currently the Chief Examiner in Immunology for the Faculty of Science of the Royal College of Pathologists of Australasia. Please welcome Associate Professor Stephen Adelstein.
Thank you very much, and thank you for the invitation to talk to you. And I'm going to talk to you a little bit differently. And I didn't find out how to advance the slides. Is that? Yeah, excellent. A little bit about the alternative side, which is the medical regulation side, and where the medical boards in Australia come into this picture. Just to put it in context, there are almost 700,000 registered health practitioners in Australia. Most of those are registered nurses. Registered medical practitioners, about 110,000, and the group in this room, there are 10,000 physicians registered to practice in Australia. APRA and the national boards were established in 2010 when the country moved, sort of, and I'll explain the sort of in a moment, to a national system of regulation. The primary role in the legislation that underpins the function of APRA and the medical boards is patient safety, but we also have a role in facilitating access to health services and to workforce development. The board has established a set of national standards for registration and for notifications about potential problems in medical practice. The one thing that has been achieved is that one can now register once in Australia and practice anywhere. The National Registration and Accreditation Scheme is complicated. And that is, and I used the word sort of in one of the previous slides, because New South Wales has a slightly different system, and Queensland has a slightly different system, and Western Australia has some exceptions to the system that applies everywhere. Essentially, the national boards and APRA are appointed by the Ministerial Council, and they work in partnership to regulate registration and notifications, the word we use for complaints, about medical practice and practice in the now 15 health professions across the country. Each health profession has its own board, and I'm a member of the Medical Board of Australia. In New South Wales, there's a slightly parallel system which deals with complaints in New South Wales, which is the medical councils, and there are councils for each of the 15 health professions in this state as well. And so notifications and complaints and disciplinary action and health programs in New South Wales are run in parallel with what happens in the rest of the country, but by the council and not by the medical board. And so the medical board functions by having boards in each state and territory, jurisdictional boards, that have individual committees, such as registration committees or health committees or notification committees, that actually consider each aspect of the regulatory work that we do. There are a number now of multidisciplinary and multi-jurisdictional committees that operate across the country. Most recently, the establishment of a Sexual Boundaries Notification Committee that again operates in the country aside from New South Wales, that looks at notifications related to issues of malpractice involving sexual boundary crossing. And there are also triage and assessment committees that I'll tell you about in a moment. As I said, the national boards operate in partnership with APRA. APRA is a regulator in its own right and deals with holding out with statutory offences about medical practice, but also acts as a secretariat for the boards of all the health professions. The boards therefore oversee registration and notifications and approve the accreditation standards and the training in institutions that provide medical training. Where does it impact on health? And as has been referred to in a number of the talks previously, there is a provision in the national law that applies across the country for mandatory notification, applies to all the professions. As Marie said in her talk, and I can only reiterate what she said, in fact, the bar for mandatory reporting is actually a high bar, and I'll give you some figures in a moment. It's based on a practitioner, and it doesn't need to be a medical practitioner, any practitioner's reasonable belief that another registered health practitioner has behaved in a way that constitutes notifiable conduct. And notifiable conduct is specifically defined in the national law as 4 different areas: either practicing while intoxicated, sexual misconduct in the practice of the profession, placing the public at risk of, and the words used are substantial harm because they have an impairment, or placing the public at risk because of a significant departure from acceptable professional standards. You will know, and the health impairment is also defined, and that is recognized to mean that it's a person who has either a physical or a mental impairment that detrimentally affects or is likely to detrimentally affect the person's capacity to practice that profession. Or we also register students or a student's capacity to undertake clinical training. In 2006-17, there were about 5,000 notifications, and I've separated the ones that were done to APRA and the ones that were done to the medical councils, about medical practitioners. There were more open notifications, and so the system is somewhat stressed, than we were able to close. Of all of those notifications, only 224 were mandatory notifications, and of those, 41 were about a health impairment, and there were 17 about sexual misconduct. Of the mandatory notifications, 153 and 103 in the rest of the country aside from New South Wales, and 103 in New South Wales were about health impairments. And what happened to those? 93 had no further action taken. In 34, there were conditions imposed by the board in that jurisdiction. 20 practitioners accepted an undertaking, 5 practitioners were cautioned, and 1 had his or her registration suspended. There were a number of doctors who were already in the system who were being monitored, and there were 1,000 medical practitioners who were monitored, 1,620 cases, because some are being monitored in both a performance and a health stream, for example, or a conduct and a health stream, for example. And so there is ongoing monitor to allow doctors who have had health impairments or conduct to continue to practice, provided they are able to meet certain conditions that are imposed. The health-related notifications by the location of practice are given in this diagram, and as you see in New South Wales, there were 63. As a proportion, and of those, 22 were mandatory notifications by location of practice. There were more mandatory notifications in Victoria, despite a lower number of medical practitioners, and the reason for that is not clear. There were also more notifications in South Australia, as you'll see, as a proportion of the number of the population. Precisely what this means and whether this is associated with reporting being, in fact, more difficult in New South Wales because both APRA and the Medical Council and the HCCC accept notifications, and in Queensland, where the notifications go through the Office of the Health Ombudsman, is not clear. APRA is very aware of the problems that have been mentioned by the previous speakers, including, and so APRA has recently, in the past year, appointed a national team of clinical advisors to provide early clinical input to try and streamline the processing of any complaints that are made, and a triage and assessment model where things are considered locally very early and then triaged so that the ones that are likely to require further investigation are assessed more expeditiously, and the ones where nothing further is going to be done are taken out of the system early. APRA has a program at the moment to engage with notifiers and practitioners to improve communication, and we are very aware of the legalistic wording that accompanies many of the letters or the communications that come from the medical board, and trying to review this. You will know from the medical literature and from the newspapers generally that there is currently a review of the mandatory reporting legislation that is being undertaken by the Council of Australian Governments. The health ministers actually released a press release in April this year. It's not entirely clear exactly where this legislation is going to go and when it's going to go, but I don't think that anything's going to change in the next year at least, because the alternative legislation has not been proposed yet. In Western Australia, and that's where there's a slight difference, health practitioners who provide health care to other health practitioners are actually exempted from mandatory reporting. The Medical Board is very aware of doctors' health programs and aware that in 2010, when the National Registration and Accreditation Scheme was established, there were doctors' health services across the country that had different levels of support and operated in different ways. And so in 2014, the Medical Board committed funding to doctors' health programs and established a national health program for doctors and health students. And this is an allocation of about $2 million of your registration funds, which are allocated to a company that has been established by the Australian Medical Association and that is therefore hands-off from its operation and function to anything that the Medical Board does. So doctors' health services contract and oversee providers in each state and territory that deliver direct support to practitioners who request it. They report annually to the AMA, who reports to the Medical Board, so that the Medical Board does not have any direct oversight of any individual cases at all that are reported or managed through the doctors' health programs in each state or territory. And providers provide confidential health-related triage, advice and referral. They provide follow-up services, they provide education and an office. They provide training for doctors who treat other doctors. And most recently, January this year, the board has committed a further $6 million over the next 3 years to extend the contract and to ensure that these services continue at least for the next 3 years. So that the board is committed to funding doctors' health programs in Australia in the future. And I'd be happy to answer any questions. Thank you.